Hi, my name is Dr. Brady Wyrick, and I practice functional medicine and functional neurology right here in southeast Idaho. We're in Idaho Falls, Idaho, and I want to welcome you to our little portion of the Virtual Neurology Summit. What I've been asked to talk about today is the neurology of pain, and I am fortunate enough to have some of my best patients here in the office as we do this. So we're doing this in front of I guess it's a live studio audience, so when the applause thing goes off, no, I'm just kidding. So I've gathered a few of my patients here tonight. The reason why I've done that is because I have a tendency of having a little bit more energy when there's people here. So we're going to go through basically the neuraxis and talk about the neurology of pain, how we test it, and how important it is to take what we're testing and to talk about that in real terms so that the patients can actually understand what the issue is, where the pain is coming from, and what can actually be done about it. So we're going to cover what's called the longitudinal level of the lesion, which basically means where is that pain coming from. We're going to talk about how it gets from point A to point B, how fast it gets there. We're going to talk about some important things about how to test it and how to take some nutritional steps to making it better. So with that being said, let's get into it and let's talk about these factors. Okay? Now, your nervous system has this really cool ability to take information from the outside world, and it goes through a process called transduction, which basically means you take a stimulus from the outside world, whether that be vibration, whether that be hot or cold, whether that be a kick in the shins. It takes that outside stimulation and it turns it into an electrical signal. That way your brain can comprehend it, whatever that particular stimulation is. And that term is called transduction. And I probably spelled it wrong, and I probably didn't write it big enough for the people that were watching the video to actually read it, but transduction. Hey, now transduction happens at nerve endings. So let's say that the nerve ending is in your hand. The skin of your hand has several different types of receptors. Okay, some of these receptors, some of them are called Pacinian corpuscles. That's the biggest word I've said all day. And other receptors are called Ruffini endings. We could go on and on with different names of these different receptors, but they all do a different thing. Meissner's, that's another one. Pacinian corpuscles sense vibration. Ruffini is deep touch, and the Meissner's are light touch. How I remember this and how I've actually taught it to other doctors in the past is Meissner's. When someone touches your skin lightly, what do you say? Oh my. That's Meissner's. Alright? Oh, come on, that was funnier than that. This outside stimulation is then transduced by your nervous system, where it enters in through several different nerve pathways. So if you looked at a nerve, and if I drew out a nerve for you, a nerve is made up of bundles and bundles and bundles of what are called axons, which are smaller nerve fibers. So one nerve, like the sciatic nerve, or the radial nerve, or the ulnar nerve, or wherever that nerve is going, one nerve is going to have several different layers, or several different sizes of nerve fibers, and they all carry different things. And they're all rated like this. So let's do this, let's color code this a little bit. Brittany, if I step outside the camera, just throw something at me, would you? Yeah. Just kidding, don't throw anything. The first one are really big nerves that come out like this. And in the neurology world, if you find it in a textbook, they're going to be called 1A nerves. For our purposes tonight, we're going to call these large diameter afferent nerves because they're really big. Large diameter afferent nerves are going to carry things like vibration, joint position sense, light touch. These are important to us because they're the most metabolically fragile nerves that you have. So as you have changes in inflammation, as you have changes in blood sugar levels, etc., this is going to be the first nerve pathway to die. And for my neuropathy patients, this is insanely important. So when you were driving down the road and you had to take your shoes off because your feet got hot, that's because this nerve pathway was the pathway that was dying. So that's the 1A nerves. between 1A, actually what they call them, I said this wrong, they're called A alpha nerves. Then we have A beta nerves. Then we skip one, we go to A delta nerves. Why do we skip them? Who knows? Oops, I meant to color code that, I forgot. We'll back up. I didn't tell you this video is going to be perfect, right? I don't believe in editing. This nerve pathway here fires at a rate that's about 120 meters per second, or in America, that's otherwise known as about 270 miles per hour. So if you're 6 feet tall, and this nerve is 6 feet long, and we're firing at 270 miles an hour, how long does that take? Pretty dang fast. Okay? Then we start going down the list. The next one we're going to talk about are whoops, I forgot to color code it again. Then the next one down the list is going to be what we call A beta fibers. Okay? A beta fibers are not quite as big, but they're still really big. A beta fibers carry things like light touch. And they also fire at a frequency that's about, a speed of velocity that's about 90 miles per hour. Okay, once we get below these nerves, this is when we get into the pain nerves. Okay, the first pain nerve we're going to talk about is the A delta fibers. A delta fibers carry what we call acute focal pain. They're still pretty big. They're still myelinated, so they still have that sheath going over the nerves that's made out of fat. And they're still fast. These guys fire at a speed of about 40 miles an hour. Not quite as fast as 260. Okay, so if you are pounding a nail and you smash your thumb, what happens? Okay, it doesn't hurt right away though, right? No. It's like whack! Oh hell! I just hit my thumb. Ow!
Yeah.
Then what do?
You suck it.
Or you suck it, or you do this, and you curse like a sailor, right? Do you know why you suck it, or why you go like this?
To calm it down.
To calm it down, but what you're actually doing is you're bringing in this large diameter pathway, the blue nerve. You're actually bringing that nerve back online to suppress that feeling of pain. Okay, joint position sense. I don't know what the sucking reflex is. I got nothing. I think someone just locked themselves out. Locking the door just bit us. Okay? Then we get down to what we're going to talk a lot about tonight. Then we get down into the C fibers. Okay? These C fibers are unmyelinated. They're little tiny guys, and they're very slow. Okay? These guys only fire at about 4 miles per hour. Now, clinically, I'm going to draw the line right here through that nerve bundle. So clinically, this will show up when you're talking to a patient about their history. So when they come in and they say, "Doc, it hurts right here," and they point to a focal spot, there is a good chance that you're dealing with one of these A delta fibers. Or when they come in and say, "Doc, I've been in pain for 2.5 years and it hurts here," or my favorite is in my intake paperwork. Okay? My intake paperwork has the picture of the dude or dudette on it, right? Like this. And it says in my paperwork, "Mark where it hurts." And they'll do this. That's how you know you're dealing with a C fiber issue with a small diameter afferent nerve. With a chronic pain nerve. So it's regional, it's chronic, it's been going on for a long time. That's when we start talking about these complex neurological pathways. Okay, so most chiropractors around the country, when people show up in their office, and even people today, like when they come talk to me when they don't know me, when they don't know what I do, it's like they'll come talk to me, it's like I've got my SI joints out. It hurts right here. Be careful where I'm pointing on camera, right? It hurts right here. Well, great. Let's put that bone back to where it belongs. You take the pressure off the nerves, and all of a sudden that A delta fiber starts going away. Okay? Those are not typically the people that I see in this office. Or they'll go out and they'll hurt themselves over the weekend. We know we have this going on, but they'll come in and say, I hope you can go chiropractic on me today because I hurt myself. Okay? So you can see both. All right, so those are the nerve fibers that are carried in that nerve bundle. Now, where these are carried in the spinal cord is vitally important. Okay, because what will happen is that this nerve, can you see the audio things bouncing back and forth? Okay, just tell me if that goes solid white, because we got a problem. This nerve, where it's going to come up, and it's going to enter into a part of the spinal column that we call the intervertebral foramen, which is basically the holes that you have in your spinal column for the nerves to pass in and out. Okay, so standard chronic, I was about to call my profession chronic chiropractic. Traditional chiropractic says when the bone is out of place, it's going to put pressure on that nerve as it enters into the spinal column, which could activate either one of those fibers. When you put pressure on a nerve doesn't function the way that it should. Anything downstream or upstream from that can be affected. So a traditional chiropractor is going to come in here, and which, by the way, this is highly, highly effective. Move the joint to take the pressure off the nerve. Allows that nerve flow to travel back and forth freely. Okay. Now, once we enter into the spinal canal, we enter into the spinal cord, and this is a cross section of the cord. Okay, so we've taken the cord. Remember, when you explain this to patients, you have to be able to put it in English for them. Okay, so when you take the cord, you cut it in half this way, and you flip it on its end like this. Okay, this is the front, this is the back. Okay, the cord is then separated into what we call the alar and basal plates, which is basically sensory and motor, but it also has in it areas of gray matter and white matter. So I draw it like a butterfly. Gray matter is gray because it has no myelin. White matter is white because it has myelin, it has fat surrounding it, so it makes it white. Okay. This nerve pathway is going to enter into the back part of the spinal canal like this. Then each one of these individual nerves is going to go in separate directions. Okay. To keep it simple, we're just going to do blue and red. So the blue nerve down here, the large diameter afferent nerve, how fast is this nerve?
270.
Fires at 270 miles an hour. Which one is the most metabolically fragile? The blue one, because it's huge. Okay? This nerve pathway is going to come into the back part of the spinal cord. It's going to come to a very, very specific part of your cord that we're going to call lamina 2. At lamina 2, this nerve pathway is going to leave a little branch, and then it's going to travel up through the dorsal column. Excuse me, the dorsal columns in your spinal cord, which is the back part of your spinal cord. Okay? Now, what I'm going to do here is I'm going to draw the brainstem. So your spinal cord, when it enters in through your skull, is actually joined right into the brainstem. And the brainstem is divided into 3 different areas. Your brainstem is divided into, the very top of it is called your midbrain, or your mesencephalon. Okay? The middle part is called your pons, and the lower part is called your medulla. Which I cannot say the word medulla without thinking about the water boy in Adam Sandler. When he's sitting in class and Colonel Sanders is saying the medulla oblongata, which is completely wrong. Okay, the medulla oblongata has nothing to do with emotion or anger. What he should have said, to make it more anatomically correct, would be the limbic system. But it's not as funny when Colonel Sanders says limbic system and not medulla oblongata. I just lost like 3/4 of you. So,
We didn't follow that.
then over here what I'm going to draw is part of the cortex called the parietal lobe. And I cannot spell tonight. The parietal lobe, specifically areas 3, 2, and 1, which are Broca's areas, which are just very specific parts of the brain. Okay? So these blue nerves will travel up through the spinal cord. They're going to enter into the lower part of the medulla here, where they have a junction. Once they hit the lower part of the medulla, another nerve is born. It's going to come across this, across the lower part of the medulla. It's going to travel up through the brainstem and then out into these parts of your brain, areas 1, 2, and 3 in your parietal lobe. All happening at 270 miles an hour. Boom. So in health, when things are working appropriately, when your big toe moves a fraction of a millimeter, your brain should say, that's where it's going. Okay, so when I take patients in, when I test this pathway, we do that. Oops, I forgot one big part of this. This goes, wow, just fire me now. This comes into a part of your brain called your thalamus, okay, which is like a train station. Information going in, information going out. There's a very specific part of the thalamus called the VPL of the thalamus. Okay, so this nerve is going to come in here. It's going to make another junction and then out into the parietal lobe. My apologies. So when we moved, when you started with me, we took your big toe and we moved it up and down. I said, tell me when you can feel this. And for some of you, that got all the way through, and I'm not pointing out anyone or staring at anyone in particular, we get all the way through, the youngest person in the room. Hey, you get all the way through that end range of motion, and they still can't tell you which way the direction the nerve is going, and which way the toe is going. Okay, so clinically when you test this, it's important that you pretend this is a big toe. You don't squeeze the nail like this. You actually grab the outside here and you say, okay, as soon as this moves, tell me what direction it's going. And anytime you hear hesitancy at all, you know they missed the test. As soon as this moves, tell me what direction it's going. No, wrong answer. 270 mile an hour pathway should be down. And there should be confidence in that answer. Anything else the test is telling us? That nerve's not working. Okay. Vibration sense. I put a vibration fork on your shoulder. I said, can you feel this? Then I put it down on your toe. Some of you didn't feel it at all. Some of you felt half of what it should, but it should be equal from your shoulder down to your toe. Your thumb, you should actually feel it a little bit more than you do either one of those two. Pretty simple to test. Hey, for some of you, I put hot and cold. Could you feel hot? Could you feel cold? For some of you, I put the electrodes on your feet, and we turned on that electrical stimulation. Some of you didn't feel it at all, and I put it on your hands. It was like, oh my gosh, that's why we feel it. Okay, this big nerve here fires at a frequency that's it's about 7.83 hertz. So the electrical signal that I put on your feet when we tested this was 7.83 hertz. I think it was called the rebuilder. That was a direct test for that blue nerve. Okay, and the reason why we use this stuff at home is because the nerves that fire together, what do? They wire together. This is a highly educated class here tonight. I'm really proud of them. That's how we test that particular blue nerve pathway. Now the pain pathways, I'm going to drive them in red, so they travel along this same pathway. They're going to come into the same part of the cord. Okay, they're going to actually make a little junction or a synapse here. And what they do is they actually travel across at this point to the front part of the cord. The tract that they follow, they go up to is sometimes called the spinal thalamic tract. Now it's called the anterolateral system. I don't know why we put these big nerves in. I don't know why they just call it. It's the pain pathway. Okay? This pain pathway is going to travel up through the front part of the cord. Now remember, it's already crossed over. It crossed over at the spinal cord, which is really interesting because sometimes you get people with sensory loss of like pain and temperature on one side and joint position sense and others on the other side because of where it crosses over. All right, but it's going to come up and it's going to travel into the same part of your thalamus and then into the same parts of your brain. What's interesting is that as it travels through your brainstem, it leaves little input with each one of them. Specifically, in your brainstem, there's a thing called your nucleus tractus solitarius, or NTS, which regulates and helps with your gut function. You ever seen someone get hurt and they puke immediately? That's why. That pain this gets stimulated because of that pain fibers, and you get an emetic event. Okay? Now, the pain pathway is actually pretty easy to test. Take a piece of monofilament, fishing line, thick fishing line. And a lot of times when you put this on patients' hands, they'll feel it. But if you put it on their feet, it's like, yow! They really feel it. Okay? You can also get this from history, from talking to people. When there's a breakdown in this pathway, these are the people that feel pain when there's no reason for them to feel pain. And when I talk about this in my seminars, it's kind of funny because when I explain that principle, that this part of your, when that blue nerve stops working, that's a pain inhibiting nerve. So when it stops working, that red nerve goes crazy because there's nobody inhibiting it. The way I explain it to people is that red nerve is like a 4-year-old little boy. When you don't supervise a 4-year-old little boy, what do? They go crazy, they do whatever they want. So for the neuropathy crowd, for the chronic pain crowd, that blue nerve is usually cooked, and that red nerve is just kind of going crazy doing whatever it wants. And then you get into these pathways, this phenomenon, or whatever you want to call it, called allodynia, which is basically, there's no dang reason for you to have pain, but you have pain. Okay? Now, you look at this pathway, and for someone who has chronic pain, how many areas could there be a problem? A lot. A heck of a lot. It could be a problem at the nerve endings. So if the problem's at the nerve ending, one of the ways we deal with this is peripheral neuropathy rehab therapy, the rebuilder that I mentioned earlier, firing that nerve pathway at appropriate levels. Okay? If we're dealing with it here, this is where we use cold laser. Cold laser can help get blood flow, nutrients, and stimulation going to those nerve endings to start to wake them up. Okay? If the problem's somewhere along the peripheral nerve itself, and from the moment it leaves the spinal cord and comes down into the periphery, it's a peripheral nerve, then you have to start looking at things like muscle entrapments. Is there a muscle crossing that nerve that's gone spastic, that's putting pressure on that nerve, causing it to hurt? Well, you release that muscle and the pain goes away. All right? If it's in the spinal cord level, there's a couple things we can do. That comes back to peripheral neuropathy. We can use pulsed electromagnetic field therapy to deal with it at this level. If it's up into the brainstem and up into the cortex itself, this is where the brain-based therapies start to come in. And we have a lot of our chronic pain patients that we use neurofeedback with them. Because neurofeedback is basically your brain uses 5 primary electrical frequencies to communicate with itself. When those electrical frequencies are out of balance, then, when they're in balance, it's kind of like a symphony that's being led by a conductor. It makes nice, beautiful music. And when they're out of balance, because we get delta waves and we get alpha waves and we get this ratio that gets thrown off, but when those brain waves get out of balance, it sounds more like a junior high band that just got their instruments. Hey, you guys know exactly what that sounds like too, because you probably just went to a Christmas concert for one of your grandkids, didn't you? Hey, this is when we start to see things like depression. Anybody want to know why depression and chronic pain go hand in hand? You have this part of your brain up here called your prefrontal cortex. This prefrontal cortex is what separates you from the animal kingdom. Okay? Pretty sure your dog or cat does not sit around all day worrying about its 401k and its retirement. Your dog or cat sees a squirrel, what do? They chase. Because they have no prefrontal cortex to inhibit that. Okay? Unfortunately, as human beings and as Americans, we have inflamed gut pathways. Those inflamed gut pathways, guess what part of the brain that affects first? That prefrontal cortex. And as that prefrontal cortex decreases in its function, you see things like depression and anxiety and the lack of inhibiting pain. When your brain can't see through this and can't say, I shouldn't be in pain, all of a sudden those pain pathways start to take off. And that's where this brain-based therapy part of this comes in. Now, if we want to make this more specific, let's get into more of the brainstem pathways, okay? The lower two portions of your brainstem, this is the on switch to your feed. I'm making up words. Feed or breed, or also known as your parasympathetic nervous system. Increasing digestion, rest, okay, slowing your heart rate down, slowing your respiration rate down so your body can relax and recover and reproduce. That's part of your parasympathetic nervous system from the lower two portions of your brainstem. Okay. Your midbrain is the on switch to your fight or flight nervous system, also known as your sympathetic system. So what will happen as brain function starts to decrease, your midbrain takes off and goes crazy. Puts us in a sympathetic state, which basically means you're not breaking your food down, you're not digesting, you're not sleeping, you're not resting. And as a result of that, chronic pain pathways increases. But we still haven't even addressed why. Why does your nervous system break down like this? Number one reason. Anybody want to take a stab at what number one is? The number one reason for chronic pain is going to be an inflamed gut. When your gut is inflamed, it's going to directly affect these nervous system pathways that we've drawn out for you. It's going to directly affect your prefrontal cortex. And it's going to put you into an adrenal response, which your adrenal glands are glands that sit on top of your kidneys that secrete these hormones called catecholamines. Those catecholamines are toxic to nerve endings right here in the spinal cord, which makes you hurt when there's no reason why you should hurt. Okay. Nutrition-wise, when we start dealing with an inflamed gut, you guys know exactly what we do. Hey, this is when we start putting you in a paleo-type diet. Meats, fruits, vegetables, avoiding anything processed, chemicals, okay, or anything that's inflammatory. Gluten, soy, dairy, those are and sugar, the top four foods to avoid to calm this pain response. I'll say that again: gluten, soy, dairy, and sugar. Okay. This is also going to help us with blood sugar management. Blood sugar levels, when they spike and when they valley, or if they just stay too high all the dang time, that is stimulatory to chronic pain pathways. And when they're spiked all the time, you're staying in a stress state, and those stress states are driving these pathways that we're talking about. Okay. Number 3 goes back to sort of the inflamed guts. That's the dysbiosis part of this. Dysbiosis basically means abnormal gut bugs. Every single patient that comes into my office has been on antibiotics at some point in their life, including me. Guess what antibiotics do to your gut flora? They break it down, they destroy it, they kill it. Okay? When that happens, it leaves you open to everything else that brings everything else in. And you get overgrowth of bacteria that are not supposed to be there. When that bacteria is there, drives your immune system nuts. All of this can be summarized into saying this. The number one reason people fall into chronic pain syndromes is because of autoimmunity. Because their immune system turns against them and attacks them. Now, when we're talking about diagnosed autoimmune conditions, what are we talking about? We're talking about things like MS, ankylosing spondylitis, lupus, rheumatoid arthritis, even some osteoarthritis. That basically means that your immune system is so confused that it's turned against you and it's attacking you, and it's bad enough that tissue gets destroyed, then they can give it a name. Okay, the people who have, here's my phone, the people who have a named diagnosis are people who walk in here, about 15% of the people we see. The other 85%, when they come in, they've got other stuff that's happening, they're not quite bad enough yet, and we have to call it things like autoimmune mycolitis. Meaning your immune system is attacking Michael, it doesn't necessarily have a name, but let's take steps like this to start calming that pathway down, to start getting people, frankly, just giving them their life back, getting those chronic pain pathways under control so we start giving them a better life. I think I've said everything that I talked about saying. I hope this makes sense to you guys. I appreciate you joining us for this. And reach out to me if I can help you at all.